بالضبط. نبدأ. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. Welcome to the Symposium of Pediatric. Actually, I have the honor today, let me say two honors today. The first one is to introduce eminent speakers in this session. And the second honor that I'm sharing this activity now with our mentor, our guide in pediatric endocrinology, Professor Abdullah Al-Hirbish. I think this is a great honor for me to be here with you. Let us start first. The first speaker, Professor Asma Deeb. She's the professor, chair of pediatric endocrinology, Sheikh Shakhbout Medical City, Abu Dhabi, United Arab Emirates. Professor Deeb is the president of the Arab Society of Pediatric Endocrinology. She is the chair of the Research Ethics Committee at the Sheikh Shakhbout Medical City and a clinical professor at the Gulf University and Khalifa University, United Arab Emirates. Please, Professor Asma.
Thank you, Dr. Al-Harbi. Do I have a slider? I have nothing. الكليكر جاي؟ طيب نستنوا الكليكر. اوكي، لأن ما فيش حتى اللابتوب هنا. طيب, okay, thank you very much. Thank you. It's always great to be in Saudi Arabia, and it's nice to have a small group of friends and colleagues to meet and discuss. It's a small group, so we can change this into an interactive session. Okay, so I was asked to just give some highlights on use of technology in diabetes. And I wasn't sure what to do, especially that Dr. Walid Qablan was supposed to talk about the insulin pump delivery. So what I thought I will do is just to talk a little bit more of epidemiology and highlight the burden of diabetes and where technology can have an impact. So this slide is supposed to show you or to remind you how prevalent diabetes is. So diabetes is a common disease. We have millions of people around the world having diabetes. As you can see here from Atlas, IDF Atlas, there are 425 million of people with diabetes, and I don't think this is the latest. Thank you very much. For our region, the MENA region, there are at least 39 million of people with diabetes. So there's a great need for finding a solution and management strategy for this common disease. This is not the only bad news, but the other expectations or prediction is for these prevalences to double, to exceed 110% in 2045. And I know we are a group of pediatricians, so pediatrics is not an exempt. If you look at the color codes there, the darker, the higher the incidence, and we can clearly see in the Gulf region, it's as dark as the most famous areas for type 1 diabetes, like the Sicily and Finland, Scandinavians, and North America. So it is a common disease, and it does not spare children, and we all need to know how to manage this disease best. Now, the main target for managing diabetes, as you all know, is glucose control in addition to others. Are we really managing to control glucose in diabetes? This is a very famous study which shows that diabetes management is a failure around the world because it's only a minority of people who achieve the target of HbA1c that's required. And people should sympathize with us, pediatricians, because the younger the age group, the harder it is to achieve diabetes control. And whenever I feel bad going home from clinic, seeing my patients with high HbA1c, I have a glimpse of this, and I see, okay, it's not just me, but everybody around the world. It's not only children and adolescents who are not achieving good diabetes control around the world. It's also adults. So our colleagues, adult endocrinologists, also struggling. 79%, according to this reference, of adults with type 1 diabetes do not achieve the target required for diabetes. And I don't think it's a tricky question to ask, why is it so difficult to manage diabetes? If we look at just a glance of a single day of a patient with diabetes who is treated with technology, we wake up in the morning, yes, pray, change, go to work, but a patient with diabetes has to do all this, starting from al-Fajr, dawn phenomenon. They start their struggle there. And even if they are on the top, highest technology use, they are still struggling doing all this. So sympathy is not enough with these people. Now, many of us has witnessed, depends on how old you are, the revolution of technology in diabetes management, going through continuous glucose monitoring, insulin pumps, combining both for sensor-augmented therapy and artificial pancreas. We've seen many of these, how it started from checking glucose in the urine until the hybrid advanced loop, and people are still starting. I don't think there's a single lecture talking technology which will not show this man from the 1960s showing the 9-kilogram insulin pump originally designed. And as we go on, we see the changes. We are now spoiled for choice of different insulin pump therapies. Now, does it really work? Diabetes technology, does it help people with diabetes? There's a wealth of data in the literature. When I attempted picking some for you today, I was overwhelmed, but multiple meta-analyses show how important technology is in managing diabetes. So if you look at this meta-analysis, for example, looking at HbA1c change with people using CGM, you can clearly see that almost all of the studies showing if you are using CGM, then the HbA1c is better. And if you are a person who does or who no longer believe in HbA1c and you say, show me time and range, you will find very similar results with majority, in fact, all of the studies in this meta-analysis showing that people who are using CGM, they have better time and range. So I don't think it's debatable. What about insulin pumps? This slide is very interesting. We don't have time to go through and dissect it and analyze it, but I really like it because it shows you how time and range improves by using different modalities of diabetes treatment. So for example, if you start with MDI and blood glucose monitoring, the maximum or the best you can achieve is 45%. And then as you add a touch of technology, so adding CGM, adding pump, using sensor-augmented pump, and so on and so forth, until you reach the advanced hybrid loop, you can see clearly how the time and range increases and exceeds 73%, which is the standard goal for treatment of diabetes. Now, this is an amazing slide that I borrowed from a colleague, which showed, we can spend half an hour talking about this slide. So this is a collection of studies The color code over there shows you what modality of technology is used, and here in the y-axis it shows the drop, or rather the elevation of HbA1c, while the x-axis shows time in range. And in each of these studies, there is a different modality of technology, and you can see the results. From a glance, you can see that the arrows, majority of them are going down, meaning for that particular modality of technology, HbA1c or time in range, or both of them, are going down. So I think this is sufficient for us to say, or at least to accept the fact that technology is a useful strategy for management of diabetes. I would like to say a few words about digital health, because we had some information about it before, and until we had COVID, then all of us, young, older, senior, junior people, were trained to use teleconsultation. We knew more about digital medicine, and it was perhaps one positive things from COVID-19, that our skills of technology and digital health has improved. It's really fascinating, this digital health issue, and it's penetrating very quickly, because it's convenient and effective, and it's high tech. And people they were initially forced to accept digital health and teleconsultation, and now gradually we understand more about it, regardless of how literate we are about technology. So lots and lots of people believe in digital health and connectivity and the technology, and it's estimated now that about 500,000 people in the US, and millions of them are on insulin pump or CGM, respectively. Now, why is technology important in health? And for us endocrinologists, I can bet any other specialty to give a model that's better than diabetes when it comes to use of technology in treatment. And look at what we are doing on a daily basis. Remote control, how many children we have going to schools, sharing their data with carers, mothers and guardians. Wireless connectivity, children and adults are using the wireless connectivity to have an idea about how their glucose profile is going. Software linkage, every single patient who walks into clinic, in some clinics, they have their devices with them, and we download their data at a convenience from our offices. It's so fancy, useful, effective, and attractive digital health. Many of us, nobody likes to have wires attached to him or her body, and having contactless and wireless, rather, is an amazing thing. One area that I developed some interest in is, or are, those fancy terms of big data, artificial intelligence, Internet of Things, and we physicians are incredibly busy learning about medicine and science, but it's very interesting for us to understand. For example, what's big data that we hear engineers talking about it, and mathematicians, and in meeting we just sit not knowing what is it. Now, I started understanding what big data is. We practice it every single day, us doctors, but we are not acknowledged as being a technical people. So if we are having this big data, it's rather a field, or I would call it an art, of dealing with systematic extraction and analysis of data from large complex data. I'll give you a very quick example about what big data is in my humble knowledge. I have many adult endocrinologists sitting in clinics, and I'll give you an example about what adult endocrinologists do at Sheikh Shakhbout Medical City. These diabetologists see around 20 patients per day. Majority of patients are on CGM. So I did some calculation. If a single physician is seeing 20 patients every 3 months, and every patient is on CGM, and the device is picking one glucose reading every 5 minutes, so that poor physician sitting in clinic will be faced with 31,104,000 data points that he or she has to analyze without exaggeration. This is the calculation that I had. So, or the spaghetti curves that we used to have. And one a paper that I'm really proud of, that I had the pleasure of contributing to this, is how to use artificial intelligence to analyze data. And in this study, there was a comparison between using softwares, utilizing artificial intelligence, analyzing such spaghetti lines, and comparing it with decisions made by endocrinologists. And interestingly, the difference is very similar. Chairman, let me know if I'm exceeding. Okay, fantastic. All right, so that's what we want to see, not the spaghetti lines. And so on and so forth. As I said, there's lots and lots of guidelines in the literature. There's lots about Ramadan. I just want to show in 2 minutes the effort that our region had under the umbrella of ASPED, the Arab Society of Pediatric Endocrinology, in this area. So this is a meeting that we had in Abu Dhabi, and we ended up producing the guidelines utilizing the trend arrows of the CGM in managing diabetes. And this is another one where I had the pleasure to represent ISPAT and work with EASD, JDRF, and ADA to show how CGM can be useful in managing exercise with people with diabetes, and so on and so forth. Multiple studies. And I don't want to show things as being always rosy, because it's not. If you look here, there are multiple reasons of why people do not want to use technology, and they avoid using sensors because of multiple reasons. But the single reason that I would like to talk about today in the remaining 3.5 minutes is cost and money. Health economics is a fascinating area that we really need to educate ourselves about. If you talk about the medical device revenue and the industry around the world, it's shocking the amount of money that's being spent. This is, for example, the US market for insulin pump, and here we're talking billions, not millions, and how it's going up and how it is predicted to grow. This is our region and how much we are paying for management of diabetes, and it's going up and up. And I'd like to highlight the role of Saudi Arabia in particular in the market of continuous glucose monitoring, because Saudi Arabia shares 37% of the market share in CGM in the MENA region. So just be aware, you are spending a huge amount of money just in Saudi Arabia for CGM. So you would rather improve it, patient care, utilize it in research, because a lot of money is coming out from you guys to pay for this. And this is my final minute or two, is now we're talking about technology and how great it is. How are we doing in our region? Do we have access? And we thought, let's look at the unmet technology needs in our region. And this, I presented this just before Corona in Madrid for ATTD, when they asked me this question: can you explore to what extent technology need is met or unmet? And I approached colleagues from around the region, India, Pakistan, ASPED region, and ran a survey on them. And the main reason for them not accessing technology for diabetes management properly is money. And then other reasons for not accessing technology properly, again, as you see, I highlighted in red: fund. So money is a main issue. It's not the only issue, because we need structured education, we need improvement in currently available technology. Not all pumps and CGMs are great. They're not all tolerated by patients. Promotion of local research is usually neglected. And with that, I think, and I'm in my last seconds of the allocated talk, I would like to say that diabetes treatment remains a burden. I don't think we can debate that. Technology has a major role in diabetes management. Digital measures and artificial intelligence are the way forward. We need to understand a little bit more and educate ourselves about them, but money remains a major challenge, and not only money, but also access of technology. It's a challenge, perhaps not in Saudi Arabia or in the Gulf, but it's a problem throughout the MENA region and perhaps around the world as well. Thank you very much.
Thank you, Dr. Asma. Nice presentation and good overlook. It's my pleasure to introduce Professor Abdullah to introduce the two coming speakers.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizing committee for inviting me to co-chair this session with Dr. Al-Harbi. Our next speaker is going to be somebody you know very well, Dr. Afaf Al-Saghir, who is a consultant pediatric endocrinologist at King Faisal Specialist Hospital in Riyadh. She's also the director of the pediatric research unit there. Dr. Al-Saghir graduated from King Saud University back in 1996. After that, she did her general pediatrics and then fellowship of pediatric endocrinology in McMaster University, which she finished in 2005. After that, she came back to King Faisal Hospital, and she is well known among all of us to be an excellent speaker. She is well known among all of us also to be an excellent researcher. She was able to publish lots of papers in international journals, and she has been invited to so many international meetings. And she is going to talk to you in the next 20 minutes or so on maybe expand her talk this morning into talking about non-nutritional rickets, which I'm sure we're going to enjoy. Dr. Afaf.
Assalamu alaikum. Thank you, Dr. Abdullah, for the nice introduction. So I'm going to talk about a disease. Maybe Esma talked about something that we are spending a lot of money on. Rickets, we may spend a lot of money on if we don't treat it. We end up in patients requiring surgeries, and actually some of my patients, I'm receiving them from our orthopedics. They were referred to them. They thought they had something that I could do something about, and they referred them to me. So I have nothing to disclose when it comes to this lecture. The word of rickets comes from an Old English word, which is ricken, which means to twist. Greek word of rickets means to bend. If you go back to the literature, you'll see some descriptions of cases of severe rickets. And at some time, rickets was very common in parts of the world where in underprivileged infants, industrialized cities in the 19th century and the 20th century. The main, reason most of the time was the nutritional rickets as a cause. It's still the commonest. We do see a lot of cases that comes to us with vitamin D deficiency. I don't see much of ricketic changes in the population I'm seeing, but I'm working at tertiary hospital where I don't see most of these cases. So what I see is usually the hereditary forms of rickets. And if you go to what's rickets, it's a metabolic bone disease of the growing child caused by impaired mineralization of the growth plate. So here you have a normal growth plate where apoptosis, hypertrophic chondrocyte, apoptosis of the hypochondric chondrocyte is happening due to the phosphate deposition. When you have rickets, there is no apoptosis of the hypertrophic, which will manifest on X-rays and also on clinical basis by the changes that you see as rickety changes. I may not need to spend a lot of time on the clinical features because you know it, where most of our patients, they come with bowed legs. Those with calcipenic rickets, they will come to us with the seizures as the first presentation. And definitely these patients may have a lot of motor delayment, failure to thrive, weakness, hypotonia, if not treated. Always when you're taking history, you need to rule out nutrition by digging more into how much these children are taking. Are they exposed to the sun? make sure they don't have malabsorption, rule out liver disease. I remember I had a patient who had hypocalcemic seizure. I saw him in the clinic, referred to me from SCACA. And the patient was being treated with vitamin D with no response. And when he came to me, I found the liver enzymes high in the report. So the doctors didn't notice he had liver enzyme, turned to have liver disease. After transplant, the rickets resolved. So pay attention to the liver enzymes. Make sure patient is not an anticonvulsant medication. And then if that's ruled out, look also to family history, and you'll find in these hereditary forms significant history of family history, which could tell you. All forms of rickets will have the same signs, maybe more in some of the cases, more than others. And when you do the x-rays, you'll see these metaphyseal changes, which is diagnostic of, sometimes I've seen case referred to me على إنها rickets, and the patient didn't have any biochemical abnormalities. He turned to have skeletal dysplasia. So sometimes these changes, you see them with skeletal dysplasia, and look to the biochemical markers. If they don't have the biochemical changes that by requesting your calcium or phosphorus, your renal profile, alkaline phosphatase, and if the patient has normal labs, then consider skeletal dysplasias. In our case, we will see abnormalities in these. Not everyone has the ability to do the metabolites, so maybe on clinical basis and look into the labs of the biochemical, you may reach a diagnosis. Always remember that the phosphate is an age-dependent, and make sure your hospital has references for that, and also the alkaline phosphatase. So this is just as an introduction to the hereditary forms of rickets. We know that vitamin D is metabolized after being absorbed from the intestine, or we get it from the skin. It will go to the liver, where 25-hydroxylase will happen. And then in the kidneys, we'll have the 1-alpha-hydroxylation, and then will form the 1,25-dihydroxyvitamin D, which will act on the receptor. So if you have in this pathway any defect in one of the hydroxylase enzymes or in the receptor, we'll have these forms of rickets. Definitely, as I said, we should rule out poor intake, we should rule out malabsorption, we should rule out the liver disease, and then if we have a very low 25-hydroxyvitamin D after that, then this could be due to vitamin D-dependent rickets type 1B. If the 25 was normal and you had the low 125, and you don't have renal failure, then this could be vitamin D-dependent rickets type 1A, where the 1-alpha-hydroxylase deficiency is happening. And if both are normal or you have a high 1-alpha-dihydroxyvitamin D, then this is the receptor defect. We all use this when we come to rickets. Is it calcipenic rickets or phosphogenic rickets? And we're going to concentrate on the genetic disorders leading to vitamin D deficiency. Also, we have the genetic disorder leading to hypophosphatemic rickets, XLH as the commonest. So these are the cases that I'm going to present next. All of you are familiar with this table. A simple way that I usually look at it when I am trying to diagnose patient. If I had high calcium, high phosphate, low alkaline phosphatase, this is hypophosphatasia. Hypophosphatemic rickets, they usually have normal calcium, low phosphate, high alkaline phosphatase, and they have normal PTH. So whenever you see normal PTH, this is not calcipenic rickets, and this is mostly hypophosphatemic rickets. It's very difficult in pediatrics to do the urine phosphate to check if they have this problem in the tubular absorption. But really, PTH does help me a lot in identifying these cases, because the other forms of vitamin D deficiencies, they all have very high PTH, and you see that in the cases. They have either normal or low calcium, low phosphate, high alkaline phosphatase, and high PTH. Sometimes, especially if you are in an area where you don't have the privileges of doing the metabolites, you could start with treating patients as a nutritional and give them time. If they don't show you an improvement within 3 months, then consider these forms of hereditary rickets. In other parts of the world, they found that nutritional rickets is the commonest, and then the second common is hypophosphatemic rickets. I'll be talking about my experience at King Faisal. I did, for the sake of the presentation for today, a cross-sectional data collection to the cases I'm seeing at King Faisal. And I found that the majority of the cases I'm seeing are vitamin D-dependent rickets type 2A. And we have two regions in the country where we get a lot of these patients. One in the south, majority are coming from Al Baha, others from the north, coming from Skaka, from Al Jof, and that part of the country. And actually, I'm trying to work on doing something for this population because they need IV calcium. We're bringing them all the way to Riyadh to get it. Why not to have satellite centers there and give them the IV calcium if they need? And the second cases that I had were vitamin D-dependent rickets type 1B, which we published data in 2001 on the largest cohort. Although still I'm diagnosing more of these cases. Currently, I'm following around 40 patients with this diagnosis. And the third came hypophosphatemic rickets. I had 35 patients of children with hypophosphatemic ricket XLH, most of them, one DBMB1, MB1. And we had now 90 cases total of XLH, whom used to be followed in pediatrics, and now most of them are followed in adult. So I'm left with the 35 that I'm still following in pediatrics. The thing, or the stories with the cases I've seen and referred to me were most of them like Tala. Tala is a 2-year-old female, referred with gross motor delayment. She couldn't walk or roll over at age of 2 years. She had history of seizures, where she was found to have hypocalcemic seizures. She had history of recurrent chest infections. She was admitted to ICU. The time she was referred to me, actually, she was in PICU, admitted for the last 1 month. I told them after she recovers, I could see her in the clinic. How she managed during the last 2 years. She got a lot of vitamin D3. Mother was so compliant. She wasn't missing doses, but she wasn't benefiting. One of the physicians put her on alpha-calcidol for 2 months, and he said that there was no response. There was positive family history of similar condition in 2 of the cousins. So what could be the diagnosis in such patient who did not respond to regular vitamin D? So most likely this patient doesn't have any nutritional, and we ruled out malabsorption, liver diseases from the history. These her labs. When I saw her, she was still severely hypophosphatemic, very high alkaline phosphatase, very severe changes in her bone X-rays. PTH was really very high, and she had a very high vitamin D. When we did the 125 diet, I thought that she has type 1A vitamin D-dependent rickets, and I did the 125 dihydroxyvitamin D, came back lower normal, around 24. This is low for her high PTH that she had. So I diagnosed her to have this entity, and I started her on 1-alpha. You would ask me why she had a trial before, why would you try it again? So I believe that our physicians are using small doses of 1-alpha. These patients need to be on at least 2 mics when you see them, and you may increase it to 3 mics daily. It took me 3 months for her to improve her levels. Now you could see her walking, jumping, running. She was severely short when I saw her around -5 standard deviation. Now she's approaching normal height. She turned to have what we thought of vitamin D-dependent rickets type 1 with confirmed genetic mutation. So this is an autosomal recessive disease. We do see a lot of cases. Over the years, we saw a number of them. At one time, we thought this is the commonest out of all hereditary form diseases of rickets, but I believe it comes maybe third after other forms. And the treatment, as I said, is the active form, but be generous when you start these patients on treatment. They will have the same biochemical changes that you see with other forms, but if you had the metabolites, you will find that the 125 will be either on the lower side or very low as diagnostic for this entity. The second case was Reem. She was wandering around for 11 years. She had a significant bowing. She was referred to me from orthopedics. She tried many courses of vitamin D. I'm not sure if she was really compliant to those treatment or she gave up on the treatment. She had frequent visits with carbobedal spasm. She had a brother who had frequent hypocalcemic seizures due to the low calcium. And her grandmother was complaining, her mother was complaining, so most of the family were having the disease. So what is the diagnosis for this patient? The same biochemical changes that you saw with Tala was happening here with Reem, but Reem had a very low 25 hydroxyvitamin D. Why would she have a very low vitamin D if she's on very high doses? She doesn't have malabsorption, she doesn't have liver disease, we ruled out celiac. So why did this patient have? I treated her with 50,000 international unit weekly for 12 weeks, and if you look at this, her vitamin D went from 6 to 55. Then I said she took the bolus or the treatment dose, let us go to maintenance. So I lowered her to once monthly, and she dropped her vitamin D. Eventually, I put her back on the weekly, and she did well on the weekly. Her biochemical markers improved. Eventually, she did not require surgery for her bowing. She was able to normalize, even straightening her legs. Her brother also was treated with the same regimen. And then we thought maybe she has this rare form of 25 hydroxylase deficiency that was reported initially from Ghana. And then Dr. Angham al-Mutair reported the family with this entity. So we did the type 2R1, and she turned to have a homozygous mutation. I had a couple of cases with the same presentation, so usually they present in a childhood with frequent hypocalcemic seizures. The rickets, the biochemical markers will be like this. As they grow up, I don't know for a reason, they normalize most of their biochemical profiles. They continue to have severe deficiency in 25 hydroxyvitamin D. I picked a number of cases from Dr. Sakati's clinic who are in their 50s, 40s, on wheelchairs, were never on optimal vitamin D supplementation, and we did treat them with good dose of vitamin D, and they did well. And we confirmed that these patients are having 25 hydroxylase deficiency. And we report this in the paper that we published in 2021. And these patients, majority of them, they had the bone pain, the limitation of the activity as a presentation, and the bowing. Hypocalcemia was in a good percentage also of these patients. We noticed also that the homozygous would manifest the disease and the heterozygous also would manifest the disease. They were variable when it comes to the response to therapy. Some people required weekly 50,000 international unit, or if you put them on 3,000 daily, they will do well. Some required every other week, and some required a monthly high dose. And 27% of those who had homozygous mutation did not benefit from the high dose of vitamin D. We ended in treating them with calcitriol. My third patient also was a girl who was born in the US, and she had a very significant seizures due to hypocalcemia. The people there, they are familiar with the nutritional rickets, so they put her on vitamin D 3,000 units for 3 months with no benefit, plus calcium high dose. Eventually, they started her on alpha calcidol, again, very high dose, and she didn't benefit. And when I saw her, she didn't have most of, maybe you could see the rickety rosary and so the widening rest. She wasn't able yet to walk. But she had frequent admissions due to seizures requiring IV calcium, although she's on this regimen of combination. So what could this patient have? It seems she doesn't have nutritional. She doesn't have the vitamin D-dependent rickets type 1 because she didn't respond to 1-alpha, very high dose. And she wasn't having alopecia. She didn't have alopecia. So that was the trick. She didn't have alopecia. So nobody thought that she's vitamin D-dependent resistance. So she turned to be, these are her levels, again, the same. She had, vitamin D was high because she's on supplement. When we did the 125, she had a very high 125. So we diagnosed her to have vitamin D receptor defect. And she turned to be positive for that. So we started Dana on therapy, and she did well on IV calcium. We gave it for 6 weeks continuously. Eventually, she ended up on oral. So not all patients with VDR, huh? لا 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 لا. This is the commonest presentation. يعني أنا عندي صقر دحين تو diagnosed. I didn't take a photo هذه من but he had the same features, and he turned to have this easy to diagnose pathognomonic alopecia. But Dana didn't have that. That was the trick. So she wasn't typical. I have Dana and Yasmin. They have, alhamdulillah, good hair. The others are wearing wigs because of the severe alopecia they have. What about management? For years, I was managing them with IV calcium, high doses. And if they do well, I shift them to oral. Now, with the distance, the patients are living far away from Riyadh, I'm putting them on oral calcium. I put a GT, very high oral calcium, around 3,000, 4,000 every 6 hours, and dramatic improvement, normalizing, even better than IV calcium. So هذا صقر, whom I just saw recently. What's interesting about صقر, on top of what we said, he presented late, 5 years of age, very late, very deformed, not able to walk. He has persistent thrombocytopenia, frequent epistaxis due to vitamin D deficiency. So, and cardiomyopathy also on top of that. So I'm done. I don't have time. Okay. So the last case is a case whom had craniosynostosis, abnormality, bowing of the legs. And when we did the labs, you could diagnose just from looking at the calcium, the phosphorus, the alkaline phosphatase, and the PTH that this patient is having. Hypophosphatemic rickets. The phosphate is low, the ALB is not as high as we see with other forms of rickets, and the PTH was normal. Still, we calculated the TMB for GFR, and it was low. So this patient was having a very high FGF23 when we did it, and turned to have XLH with fixed gene mutation. And this is differential. For that could be, if you have the FGF23 mediated, you see it with fibrous dysplasia, you see it with XLH. I have one case of autosomal recessive. I don't have the autosomal dominant forms. The non-FGF23, we see more than the FGF related because we do have a lot of Fanconi-Bickel syndrome who are presenting also with hypophosphatemia. And what's unique about XLH or hypophosphatemic rickets, they have the dental abscesses frequent. It's very challenging, long life, debilitating disease. But with the new treatment now that we have for this entity, we are hoping that these patients will do better. These are all patients most of them from King Faisal. Some of them with Dr. Fahad are followed at National Guard. We were entertaining them in one of our campaigns, and you could see how deformed is the lower legs. These patients now are Purizumab. We hope that this patient will not end like this family with severe case of XLH, 35 members affected. We just saw them with Dr. Zilf in Jeddah, and we are trying to help this family also with the new modalities of therapy. So in our area, we see a lot of rickets. Always consider hereditary forms, a good history, careful interpretation of your data, close follow-up of your patient, and you will reach the diagnosis. Thank you.
Thank you very much, Dr. Afa, for this really great presentation of very interesting cases. As indicated before, we will have few minutes later on for addressing questions and comments. But now let me move to the third speaker in this session, Dr. Aisha Sinani, who is well known to most of you. She is a consultant pediatric endocrinologist and the head of pediatric endocrinology in NDEC and Royal Hospital. She is a member of many international societies, including ASPID and the Oman Diabetes Society. Actually, I came to know Dr. Aisha many years ago when both of us worked in the same department in King Khalid University Hospital in Riyadh, when she did her subspecialty of pediatric endocrinology. And I really, at that time, found her a very dedicated person towards her patients. and a very brilliant lady who was pushing all of us to think more and more when we see challenging cases. Dr. Aisha was able to to publish in international journals her research, and she was able to put together lots of protocols in management of pediatric endocrinology and diabetes in Oman, where she works. So she is going to present today over the next 20 minutes or so something about pseudo-hypoaldosteronism. Dr. Aisha.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to thank the organizers and Prof. Al-Hirbish for the nice introduction. I think there's a problem in downloading my presentation, and he is doing that. If it is not ready, maybe we can ask the other speaker to talk, and then I will. لا هو في خطأ في الداونلود. Pseudo-hypoaldosteronism.
Okay.
What is this one? This to go up and down? Okay, see this. Okay, thank you. So this, just I'm requested to talk about the clinical presentation of pseudo-hypoaldosteronism. How it is not moving? Excuse me? Not moving? Yes. لا هذا not moving. Okay. What's happened? And it seems that my presentation doesn't work well. Yeah. Let me see. This is the neck. This is the previous one. Okay. So we'll go to, before go to the introduction, this one, and this is to go for the next line. So I have to go for the next from here. Moving, he's moving it. ممكن ترجع لو سمحت. From here, لا. Okay. بسم الله. So my presentation outline will be about introduction with the clinical cases, and then I will talk about the pathophysiology, and then about the clinical presentation of pseudo-hypoaldosteronism, and then I will go through the genetic case series, which was done by our local area. So I would like to share this slides. Though pseudo-hypoaldosteronism, it is a rare, but as now everyone is going through the electronic, and they meet to each other from many countries. As you said, they have their Facebook, and their parents and the patients log to the Facebook, this website. But from our area, there's none of our patients known maybe about the Facebook of this society. So if you have any patients with pseudo-hypoaldosteronism, advise them they can log in and they can follow them. When the clinical cases are presented to us, almost always they will come a newborn baby, or there's a neonate who presented with hyponatremia, hyperkalemia, and metabolic acidosis, and then the referral will be to whom? Should be referred. Is it to the pediatric endocrinologist or to the nephrologist? As you said here, the kidneys and renal are almost close to each other. So we face this scenario many times in our institute, in which the patient referred initially to the nephrologist and to have a congenital adrenal hyperplasia. So the hypoaldosteronism, actually, it is a disease of electrolyte metabolism due to the unresponsiveness of the aldosterone action. It manifested mainly by hyponatremia, hyperkalemia, metabolic acidosis, and with normal GFR. It is classified into many types, but which is here about as for pseudohypoaldosteronism type 1, first described in 1958, and it is also subdivided into renal and systematic, and I will go in detail about this type. The other one is the transient pseudohypoaldosteronism. It is actually associated with urinary tract infection, or if there is any abnormality of the urinary tract. And this can be mislead because all they are presented on the same clinical presentation. And the other form is type 2, which we call also known as Gordon syndrome, and it is inherited as autosomal dominant, and the presentation with this, the cardinal presentation is hypertension with hyperkalemia. Yes, we cannot skip this slide. Everyone is familiar with this slide, how the aldosterone is produced from the adrenal gland. So to go in detail, we will talk, this is the nephron, and if you will see the aldosterone action, it will be in the distal tubules. So what will happen there will be reabsorption of sodium chloride, and there will be excretion of potassium and hydrogen. If we go more closer, you will see the epithelial cells with one of the ENaC. The ENaC, that means the sodium channel, which is presented in the apical part of the epithelial cell, in which I can use this one as a pointer. No. Okay, no. Okay. So when the aldosterone is acting to the receptors, that the red one, there's an MR called the mineralocorticoid receptors. So if there is activation of this complex, it will activate the ENaC. ENaC, it is the sodium channel, in which result into the absorption of 3 molecules of sodium and excretion of the potassium. We come more in depth about the ENaC. It is located actually in the apical membrane, also of the distal colon, in the salivary glands, as well as in the sweaty glands. It has 3 units, alpha, gamma, and beta, and the gene's defect will be one of in these units. So if there is a gain of function mutation of the ENaC, this will result into what we call Liddle syndrome, present with metabolic alkalosis, hypertension, and hypokalemia, and the aldosterone will be low. But if there is a loss of function mutation, this will result into pseudohypoaldosteronism. So the genetic mutation, actually, it has encoded by 3 genes, the SCNN1A, B, and G. And these mutations, if there is affected in the ENaC, it will result into the pseudohypoaldosteronism type 1B, which is called autosomal recessive. If the mutation will be affected in the aldosterone mineralocorticoid receptor, this results into the type 1A. Also, this is called as the renal one. So I will present my case. The pseudohypoaldosteronism is rare, but we have a family in which each family have more than one affected patient. This patient is 16 years old. He's a male, and he's presented his background actually during the neonatal period. And the typical presentation, he was presented with rhinitis, extensive erythema, neonatum, toxicarum, and poor feeding, but there was no vomiting. During that time, his examination showed there is an active boy, active neonate. He doesn't have any respiratory distress. His blood pressure was maintained. His weight is 2.6, so he is having low birth weight. He got an extensive erythema all over the body. Systemic examination at that time was unremarkable. This is the family tree. He got 3 others, three of affected. The eldest sister, now she is 23 years old. She is short, and she attained puberty late by the age of 17 years. The second brother, he's 21 years, and he's short, and he's attained his puberty by 16 years, and this is the 16 years is the current patient. The lab result during the neonatal period showed hyponatremia, hyperkalemia. There is أنا اليوم Okay, there is hyponatremia, there is hyperkalemia, as you said there, the metabolic acidosis, and the renal function was normal, but his urea is in the high side because he's dehydrated. 17 OHB at that time was normal, his cortisol is normal also. Aldosterone was very high, as well as the renin is very high. Ultrasound at that time was normal. So this boy at that time, we diagnosed him as pseudohypoaldosteronism type 1B, and he's treated, admitted, treated, and discharged home on this medication, sodium chloride, sodium rosonium, and Ural, and also referred to the dermatologist for their input, and they put him in antihistamine fusidic acid cream for a period of time. So what's the clinical presentation of different types of pseudohypoaldosteronism? Sorry. Okay. The systemic type, also known as multiple target organ defect, and they're presented with the salt wasting. Presentation, it is more severe than the pseudohypoaldosteronism type, the renal one, and actually they have a high incidence of lower respiratory tract infection. And this is they presented most of the time with either wheezing or a pneumonia, and there I found a study this about what is the pulmonary epithelial sodium channel dysfunction in the airway. They found that those patients with pseudohypoaldosteronism, they fail to absorb the liquid from the airway surface, and this results in increased the fluid of the airway inside their airways, which brought them to the infection. And this can mimic cystic fibrosis. The other presentation of the multiple, it can be also misdiagnosed and referred to the dermatologist because they are presented with miliaria rubra, and they can be having lost their salt in the serum and accumulation of the sebum in their eye, and this will affect to the channel of the sodium. And here another reported case, this in 2015, about a newborn baby who presented, and you can see the clinical presentation of the severe edema notosa, plus there is exfoliation, and in other published case, you can see how the clinical presentation of these newborn babies during the neonatal period. So this is what is called in the sebum accumulate in the eye, and this accumulation of the sebum gives you the illusion that there's like a teeth in the eye. We'll come back to our case. Actually, our case, we did the genetic study in King Faisal by Dr. Ali, and then they found this patient, he's having a novel nonsense mutation, and you can see it is in the 1B mutation, and it is a novel one. So our patient admitted many times, almost monthly, he used during the neonatal period with crisis. Until today, he's coming with a clinical crisis. Last admission was in May, and the last admission is just when I came here, he's still admitted, discharged yesterday from the ward with severe hyponatremia, hyperkalemia, metabolic acidosis. His growth parameters during the last visit showed that his height is only 142, and his weight is 34. He remained very well below the percentile for his age and 6. His skin was very dry with angular stomatitis, and I didn't examine his tanning, so he didn't allow me to examine the tanner stake, but I did for him FSH and LH and testosterone, and it seems that he started to enter his puberty. This is his last photo. As you see that he got the angular stomatitis. You see the philtrum of the nose. This is due to, before he got severe exfoliation, but it now still hypopigmented. You can see the sebum over in the eyelids. And here, because he got this own skin manifestation due to the tears wanted to come in his face. So we'll go to the renal type, how it is presented. Actually, those patients with the renal type, during the neonatal period, the presentation is almost the same as the systematic type, but they may present late, few of cases with failure to thrive. They have vomiting and dehydration. The children may be, if they presented late in the childhood, they may come with hyperkalemia and with the short stature. The good long prognosis is much better, even if they are presented during the neonatal period with the severe presentation. And we can wean the sodium and the resonium very well as they grow up. This renal pseudohypoaldosteronism, actually, they can vary even among the same member of the family. Even if they are sisters and brothers, they're having the same genetic mutation, they can vary in their clinical presentation. And that's the same slide, this repeated one. The other thing that they can present with salt-wasting polyuria can present in utero, and this can result in polyhydramnios during the antenatal period. If you look to this table, just see the comparison between the two. You can see the genetic, it is different in the mutation, and the only thing that the long-term outcome is much better in renal form compared to the systematic form. We come to talk about the pseudohypoaldosteronism type 2. Actually, it is present at any time, from birth till adulthood. The cardinal signs that they have hypertension. So they will have volume expanded and hypertension, plus they will have hyperkalemia, they will have hyperchloremia, metabolic acidosis, their renin will be suppressed, and the aldosterone will be in the high side. If any adolescent presented with hypertension and hyperkalemia, then we should suspect that those patients may have pseudohypoaldosteronism type 2. Even those patients can present only with the short stature. So short stature may be the only manifestation of pseudohypoaldosteronism type 2. This is the other names which is given to the renal type. Transient pseudohypoaldosteronism. So I'd like to share with you this publication. Actually, this is a case published and we'll come to a detail. This is presented at the age of 2 months with the hyponatremia, hyperkalemia, metabolic acidosis. They found renin was high, aldosterone was high, and the baby was diagnosed as pseudohypoaldosteronism systematic type and sent home with all medication. He responded partially to the treatment, and after 3 months from the treatment, he came back at the age of 5 months with the bilious vomiting, and then he was evaluated why he got this bilious vomiting for intestinal obstruction, and they found that there is gastric dilatation and small bowel also obstruction. Even though ultrasound during the neonatal period for this baby was normal, but when he came at the age of 5 months, the ultrasound showed there is evidence of intestinal obstruction. He was taken for laparotomy, and there was diagnosed as a duodenal web. So this duodenal web, after this surgery, he was discharged, and he improved, and they were able to stop the medication. So this transient should not be missed. This is another table, just compare between all types of pseudohypoaldosteronism. I went through it in detail. So what's the differential diagnosis for those patients? If the patient comes with hyponatremia, as you said here, hyperkalemia, there will be high aldosterone or high renin, and there will be also the patient having differential diagnosis with congenital adrenal hyperplasia, and we should also put in our mind the renal tubular acidosis type 4. I will go through the genetic case series. Unfortunately, there is not a lot of publication in this. Our case, which was presented by Dr. Zahrani, is the highest, the biggest number of patients. So this is the unique genotype of pseudohypoaldosteronism type 1B in a highly consanguineous population. The objective of this study was to describe the molecular genetics of pseudohypoaldosteronism type 1B in a highly consanguineous population in the Gulf region, and the patients were collected from Saudi Arabia and from Oman. I will go through the method here. They studied 22 patients, so this is the large size population of pseudohypoaldosteronism published in the world. So from 13 unrelated families, 2 families from Oman with 5 patients, and 11 families from Saudi Arabia. They have 17 patients. All the patients presented in the first days of life with nausea, vomiting, hyponatremia, hyperkalemia, and hypotension. And they took the DNA from the peripheral blood, and they tested for the common gene. Initially, if it comes as negative, they will go for the uncommon genes. So this is the table which represents the biochemical characteristic of 22 patients. So you have the percentage, and here about their biochemical. So patients presented in that study soon after birth. Okay, nausea and vomiting almost universal among most of the patients. 50% of the patients they present with hypotension, and almost 72% they got respiratory symptoms presented, and 31% they present with dermatological manifestation, which occurs only in 7 cases, and 91% they present with growth retardation, and 5 patients initially they have UTI, but the symptoms of pseudohypoaldosteronism persist even after the treatment of the UTI. Hyponatremia, hyperkalemia, metabolic acidosis, high renin, and high aldosterone was variable, severe in the hallmark of the biochemical finding of our patients. The patients, they managed with the sodium and sodium resonium, sodium bicarbonate, and oral, and this is the oral resonium. And they did well with this treatment. 1 patient only able to wean the medication out of the 22 patients. So we'll see about our mutation here in our patient. The 6 patients, they have the mutation in the SCNNA, and all are novel mutation except for 1 patient. And all those patients having this mutation from Saudi Arabia. And from our patient, 1 family, the same one I presented now, he got the SNN1B, and it is all the mutation are novel mutation. And the other family also, there are 2 siblings from our hospital, also they have a novel mutation. But the one is nonsense mutation, and the other one deletion mutation. So this is the novelty of our studies. And this is also the detail about the genetic. So from this also publication, they say there's any genotype-phenotype correlation. And they found that the genotype-phenotype correlation has not been yet described well. And there is some variation. All affected patients to have similar clinical and biochemical feature. And the disease were severe to very severe. Yes, after the diagnosis there is some improvement. And this is 1 patient. Although the data do not support the different genotype-phenotype correlation, the single point mutation, actually they are more, they present with less severe disease compared to the others. Patients who have structure disrupting mutation, such as deletion or frame shift mutation, or they will have more severe presentation, and they persist to be having a severe course. And this is, I found here another study which also study the phenotypic diversity and correlation with the genotype of pseudohypoaldosteronism. And the aim of that study was to review the clinical presentation. And they conclude that it is impossible to differentiate between types of pseudohypoaldosteronism from early clinical presentation or the biochemical and hormonal profile. Clinical course differ between patients with the renal type, but with the type 1 mutation, there is no difference. And they said they conclude there is no obvious genotype-phenotype correlation between mutation on the same gene in their cohort and others. So this is their cohort. But what I found that this study, the ethnicity, most of the patients they studied are from the Asian. They are Pakistani. They are none from their region. And the other, I like this complication, their conclusion. The patients, the renal type, most of them, they improved and they don't have any complication. However, the systemic type, there is a death due to the cardiac arrest and due to the arrhythmias. So there is, and they have recurrent infection. This is the last slide. So in conclusion, so the hypoaldosteronism is a life-threatening disease due to serious salt loss. Differential diagnosis from other adrenal insufficiencies is very crucial because the treatment is all different. Usually they present with fail to thrive, poor feeding, and they have potential to shock. Okay, autosomal dominant has a better prognosis than the other one, and there is no clear genotype-phenotype correlation exists till now. Both forms can decompensate during the neutral period when they are unwell, and this may result in cardiac arrest and death. Life-threatening arrhythmias can present due to also hyponatremia or severe hyperkalemia. I would like to thank you. This is my hometown, Sur. I'm inviting you, inshallah, to do the other gaed in our country. Thank you.
Thank you very much, Dr. Aisha, for this very nice and clear presentation.
Good morning, ladies and gentlemen, friends and colleagues.
Just 1 second.
It is my pleasure to give a lecture in this
excuse me. Can you stop
prestigious
this?
meeting. I would like to thank the organizer for the invitation.
Can you stop it? We haven't.
Unfortunately, I could not join you because of medical reasons.
Sorry. I would like to hand over the podium and the stage for Dr. Al-Harbi to present the next speaker and to moderate the discussion.
Okay, our last speaker, Dr. Kablan, Walid Kablan, is a consultant pediatric endocrinologist and the chairman of the Department of Pediatric at Tawam Hospital, Al Ain, United Arab Emirates. Previously held the position of interim chief medical officer and acting chief quality officer in the same hospital and assistant professor of pediatric endocrinology and metabolism at the Baylor College of Medicine, Texas Children's Hospital, Houston, in the United States. Dr. Kablan received his medical certificate from Damascus, Syria, completed his pediatric residency at Michigan State University and subspecialty training in pediatric endocrinology at Baylor College of Medicine, Houston, Texas. He is certified by the American Board of Pediatrics in pediatric endocrinology and has participated in the U.S. for many years. He is currently involved in a full clinical and teaching responsibility as Tawam Hospital and the School of Medicine, United Arab Emirates University. His research interests include diabetes in Ramadan, growth disorders, and calcium bone mineralization disorders. He has published widely in these areas and given oral and poster presentations at many regions and international meetings. Dr. Kablan, unfortunately, he had some issues, let us say COVID, and his presentation will be recorded. Please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, ladies and gentlemen, friends and colleagues. It is my pleasure to give a lecture in this prestigious meeting. I would like to thank the organizer for the invitation. Unfortunately, I could not join you because of medical reasons. I am recording this lecture a day before, but I will be online when the session runs for any comments and questions. I apologize if my voice gets out of order as I'm recovering from my conditions. I will be talking today about the automated insulin pumps, and my lecture will cover the following points. Recommended insulin regimen in type 1 diabetes, the insulin pump type plan over the past 5 decades, the features of the most recent insulin pumps, the approved one mainly, and I will show some clinical outcome data in relation to the recent pumps. I'm going to start with a warm-up question, and I'm not going to show you the answer until the end of the presentation. What year was the HbA1c established as a marker for diabetes control? Was it in 1966 or 1971, 1976, or 1980? Do not Google the answer, just think of it, and I will show you the answer at the end of the presentation. So the DCCT, a landmark study in type 1 diabetes, has showed clearly that the intensive insulin regimen is superior to the conventional regimen in reducing HbA1c, minimizing the microvascular complication of type 1 diabetes, improving the cardiovascular outcome, and reducing the myocardial infarction and stroke, and also reducing the long-term mortality rate after following these subjects for almost 3 decades. Following the initial publication of the study, the treatment of type 1 diabetes was shifted from the conventional regimen, which we all might have heard about, giving insulin twice a day, either premixed or separate, into what is known as the basal bolus regimen. And the basal bolus regimen can be given either in the form of multiple daily injection using insulin pens, or rarely syringes in some countries maybe, or it can be applied by using the insulin pump. So history of insulin pump goes back actually 60 years ago. You're probably all aware of this picture. This is the first invented insulin pump. It's quite big, quite heavy, very noisy, not quite reliable, even though it was made to give 2 hormones, insulin and glucagon. However, it was not widely used because of its size, noise, and inaccurate dosing. The first portable insulin pump were basically made about 10 to 15 years later. Those used to be called either the auto-injector, or the nickname was the brake pump. The reason they're called the brake pump because they are the size of the brake used in the construction in the US. Those pumps also had some issues with the accuracy of dosing, insulin leakage, needing to be charged, and they were used with limited benefit for certain group of population. It wasn't until the 1990s when the insulin pump started to look quite similar to what we see today in terms of size and buttons and shape and stuff like that. And insulin pump in the 1990s all had about the same common features summarized in the following in this slide. First of all, the basal rate can be preset and can be changed into different pattern, up to 20 or 30 times per day, or nowadays actually 48 times per day, 48 intervals. This can be changed to match the patient's eating pattern and lifestyle. All insulin pump has the option of giving manual bolus and do manual suspension to interact with the hyperglycemia and hypoglycemia. Insulin pump gives the ability of delivering a very small fraction of a unit of insulin, which is essential in managing diabetes in neonate and toddlers, where we need to give sometimes 1/10 of a unit or even less than that. And we cannot do that with the insulin pen or syringes. And insulin pump cannot do any errors when they calculate the sensitivity factor and the insulin to carb ratio. It's a simple calculator built in. And as I say, the insulin pump in the 1990s and after all had a very reliable and accurate dosing, unlike the insulin pump in the generations below, earlier to that. However, in the beginning of this century and onward, we started seeing the birth of what I call the smart pumps. And in the past 20 years, or maybe actually 15 years to be more accurate, the pumps have gone through a significant improvement, and I will walk you through those stages. So non-automated pumps are the ones I have just mentioned, the pumps of the 1990s. They give a basal rate that can be preset and changed according to the patient's lifestyle. We can do manual suspension, we can do manual boluses, and nothing else can be done with these pumps. They're non-automated. In 2006, the first integration between CGM and insulin pump was basically developed. Now the reading of the CGM can be seen on the screen of the pumps, and a built-in alarm will alert the patient to the hypoglycemia and hyperglycemia. However, each device continues to function totally separately, and the operator or the guardian has to do the change in setting or put the information in the pump to make changes according to the trend in the glucose reading from the sensor. In 2009, we had these sensor augmented pumps. So now the pump can go in automatic shut off once the sensor detects hypoglycemia. And this automatic suspension will last for 2 hours, regardless of how the glucose is trending. So in a sense, this was a great improvement because it would minimize or shorten the hypoglycemia. But at many reported cases, patients were running into extended period of hyperglycemia before the pump is restarting again. And in the year 2015, we had the first pump with the feature of predictive low glucose suspension. So now the sensor has an algorithm that can predict hypoglycemia if it would happen in the next 30 minutes or so. And if it does, or if it does detect this trend, it will make the pump to shut off earlier so that the hypoglycemia can be avoided. And then the suspension of basal insulin does not necessarily last 2 hours. It can be resumed as soon as the sensor shows a recovery of the trend down and it is safe for the pump to be resumed. 2017, we had the first hybrid closed loop pump. So now the first time the pump is going to take action, not only for the hypoglycemia, but also for the hyperglycemia. It does change in the basal rate up and down according to the change in the glucose from the CGM readings. However, no boluses can be given. And most recently, we have the advanced hybrid closed loop pump, where the pump can take the same preventive measures to prevent hypoglycemia in the previous generation. But in addition to that, it will take more aggressive action to control the hyperglycemia by either making more sophisticated changes in the basal rate or by giving automated boluses in some of the models, which I will show you later on. So out of the 6 developmental stages foreseen by the JDRF to reach the fully automated insulin pump, we are now at stage 4, where the pump can work for hypoglycemia and hyperglycemia, but it still needs the patient's input for the meal intake to deliver the proper boluses for the prandial insulin. Stage 5 will be the fully automated insulin pumps that needs no patient input at all. And again, the 6th stage is thought to be for the multi-hormonal insulin pump, which I personally am not sure if that's going to be necessary with the sophisticated algorithm that we see in the pumps today, where insulin alone is able to control the hypoglycemia and hyperglycemia very effectively. So what are the currently approved advanced hybrid closed loop pumps? There are 3 main brands. They might not be all available in the same country, so I'm going to show them to you, and some of those are used in some geographic areas and the others used in the other parts of the world. So the first one is the Medtronic 780G, and it has the system known as a smart card, the Tandem T-Slim X2 with a Control IQ system, and the Omnipod 5 with the Smart Adjust system. So let me show you the main differences between those 3 pumps and the features or unique features of some of them. So the Omnipod 5 is the only tubeless pump. The other 2 do use a tube as a standard. All the pumps have a predictive low glucose suspension feature, and the Medtronic and the Tandem, it detects glucose for the next 30 minutes, but the Omnipod claim that the algorithm actually does predict the hypoglycemia for the next 60 minutes. They all have basal adjustment to basically counteract the changes as seen from the CGM reading. The correction boluses are more aggressive in the Medtronic. The system allowed the pump to give bolus every 5 minutes once glucose exceeds 120 milligram per deciliter, while in the Tandem, the boluses can be given only every 1 hour and only when the glucose exceeds 180 milligram per deciliter. However, the pump interacts with the increase in glucose level above target by making adjustment in the basal rate, while in the Omnipod, there are no bolus option. All the changes are done by adjusting the basal rate. The CGM used in the Medtronic is their own Guardian that has been used in very many years. However, Guardian 4 is the first CGM for Medtronic that needs no calibration, and it works for 7 days. The Tandem and Omnipod are using the Dexcom G6. It lasts actually for 10 days, and it needs no calibration. The official age approval for use of the pump is for 8 and older for the Medtronic, 6 and older for the Tandem, and 2 years and older for the Omnipod. They're all are water resistant, and actually the Omnipod claim that you can swim in the pump for up to 30 minutes. The Medtronic and the Omnipod has what is known as the adaptation. It's an artificial intelligence feature that make the pump learn from the patient's day-to-day variability and make further changes. So they claim that down the road, a pump will be more effective in controlling the glucose variation weeks and months down the road than when the patients start using it. Probably we need to see that in a real evidence. And then a unique feature, the Medtronic has the Arabic language software. It has been in the market long enough. It has excellent customer support service. The Tandem has gained an excellent popularity in the USA. It has a touchscreen operation. Most of my adolescent patients, when I used to practice there, liked it so much because they can make changes much faster, like similar to any smartphone. And when the pump is upgraded, they do not need to replace the pump. They just need to update the software, and the pump become basically like a new pump. The unique feature about the Omnipod is you do not need the operating monitor to run the feature of the pump. You can use any Android phone with the application, and all what the patient need to have with him is the pod and the sensor and his personal mobile, and he can control the pump in full. And that was found a very favorable feature, especially by those who are athletics. The use of insulin pump has increased remarkably in the past 10 to 15 years. As you can see in this graph, that the patients of younger age groups, the toddlers, the pre-adolescents, and adolescents are using it more increasingly compared to the adult patients, whether we're talking about the pump alone or the pump and CGM in combination. But as you can see, there is an increase in all age group because they're gaining more confidence and popularity. So what are the clinical outcome data? I want to bring your attention here that you need to be careful when you look at the older data and the recent data. The older data compare the older pump, the non-hybrid closed loop pump, to the MDI. The recent data in the past 2 to 3 years is basically, mainly in the past 2 years actually, is comparing the automated insulin delivery pump or the closed loop pump versus the open pump. And you can see the difference yourself. And you can tell most of the data from the older study do not necessarily apply to the newer pump. I'll show you a few examples of the older studies. Here's meta-analysis of all the studies, randomized controlled trial done between 2003 2014. They had a total of 8 studies, 312 patients, and they concluded in this publication that there was a very minimal improvement in HbA1c by 0.25%, but there was no difference in total daily dose of insulin, DKA occurrence, severe hypoglycemia, or in the rate of change of A1C from baseline to the end of the study. Here is a Cochrane review of 3 randomized controlled trial, total of 150 patients, and they found actually no difference in anything. Same HbA1c, same weight, same total daily dose of insulin, and even they looked at the time in range and they found it same. And they said that the pump was more expensive, and this is the first time I see studies reporting a lower quality of life in the pump compared to the multiple daily injection. However, that's what these 3 randomized trial reported. And this is one randomized control study from UK, almost 300 patients, 50-50 between insulin pump and multiple daily injection. They were followed for 1 year, and they found no difference in anything, whether the mean HbA1c, percentage of HbA1c at target, severe hypoglycemia, or incidence of DKA. And they say that the MDI is more cost effective. Again, this is the old data showing the older insulin pump compared to the multiple daily injections. There were some other studies that showed actually different results favoring the pump compared to the multiple daily injection. What about the newer data that have compared the closed pump or the automated insulin delivery device to the open loop pump? Here's one study in the New England from 2020. They looked at 101 children randomized into either sensor augmented pump or the automated hyperclosed closed loop pump, and they followed the patient for 16 weeks. The main point was the time and range. So the baseline time and range was similar between the hybrid closed loop and the sensor augmented pump. By 1 to 4 weeks, the time and range has increased, and the difference was maintained through the 16 weeks of the study observation. It was 11% higher in the hybrid closed loop pump. And when they looked at the 24 hours, the main difference was in the nighttime and the early morning hours. Here's another meta-analysis of 19 studies, total of more than 500 patients, all adolescents, all with type 1 diabetes. And they found that the time and range has increased 12% comparing the closed loop versus the open loop. The hyperglycemia was down by 3%. The hypoglycemia was slightly down by 0.7%. And this is 1 year of real-world study comparing 101 children who were classified into 3 groups, 27 one of them on non-automated pumps, 29 subjects on the predictive low glucose suspension, and 45 patients on the hybrid closed loop pump. And then they found after 1 year that the time below range was the lowest in the hybrid closed loop pump, the time and range was the highest, and the severe hyperglycemia was the lowest in the hybrid closed loop pump. Similarly, the glucose management index was better in the hybrid closed loop, and the glucose variability was the least. And they put that in their conclusion that the hybrid closed loop pump are superior in controlling diabetes while minimizing glucose variability. And here's a study comparing the same brand, an automated Omnipod, which is Omnipod 5, to the basic Omnipod, which is Omnipod Dash, and 2 groups of patients, adolescents and adults, 128 subjects, pre-adolescents and patients of 113 subjects, observation for 3 months period. They found in the adult and adolescents that the time and range increased by almost 10%. The HbA1c has dropped from being good to being very good. The hypoglycemia has gone down by almost 50%. And in the children group, the time and range has increased by 16%. And HbA1c dropped by 0.7%. And finally, the type 1 Diabetes Exchange has released a recent data in adult population, more than 12,000 patients with type 1 diabetes. About 1/4 of them is using the automated insulin delivery. And when they compare the patients who are using automated insulin delivery with MDI, HbA1c was significantly better. Severe hypoglycemia was significantly less. The same findings were found between those who are using the automated insulin delivery device versus the pump without an AID, and again between patients who are using the hybrid closed loop and patients who are using the pump with the predictive low glucose sensor only. The use of insulin pump is endorsed strongly by the American Diabetes Association. Most recent guideline, they stated that the pump can be used safely and effectively in youth with type 1 diabetes to achieve all these goals: control type 1 diabetes, minimize hypoglycemia, improve quality of life, and hopefully minimize the long-term complication. The SPAD similarly put in their clinical practice guidelines of this year that the insulin pump is the preferred method of treating preschool children, and those devices should be made available for this age group. It actually provides a greater flexibility and better means to deliver very small, precise doses of insulin injection. There are disadvantages for insulin pump though. They are very expensive. If they're not covered by insurance, no patients can probably stand the expenses of the device and the consumable. They are still operator dependent. So as of today, patient is still required to enter the carb intake or the meal portion. So otherwise, they will go into postprandial hyperglycemia that will be corrected, but it will take several hours to be corrected. The infusion set need to be changed every 3 days, and unfortunately, some adolescents tend to keep it 4 days and 5 days, and it will be at higher risk of being occluded. And as any device, it might go into technical malfunction, but fortunately, this does not happen very frequently. So what is next? This is from the one company, the Medtronic. They're telling us that a disposable CGM is expected to be available in less than 1 year. They're working on infusion set that will last for 7 days, which is great. Now, patient does not need to change it every 3 days. They're also working on combining the CGM and the infusion set into one port, so patient does not have to have 2 insertions in 2 separate places. And eventually, they're looking to have all-in-one patch device that have a full closed-loop features. I want you to know quickly about the do-it-yourself or the open source option. Those are a mobile phone application available for anybody. They can work with generic insulin pump. They can work with any CGM. And there's a recent publication in the New England Journal of Medicine comparing the do-it-yourself option with the open loop insulin pump, and it shows superiority in maintaining time and range in adult and children, as you can see in this slide. The other thing I want you to be aware of is the islet bionic pancreas. I did not talk about it because it is pending FDA approval. This insulin pump does not require carb entry. All what need to be entered in the pump is the patient weight, and the patient has to put the portion of the meal. Is it usual portion, more than usual, or less than usual? And then the pump will do the rest on its own. There was a recent publication last month in the New England Journal of Medicine showing that this pump has actually excellent outcome when compared to a control group. It had actually a better time and range in both children and adults. However, the control group had a combination of patients who were using an MDI, an open loop pump, predicted low glucose suspension, and a hybrid closed loop. So they put them all in one group and they made the comparison when they switched them to the bionic. Nonetheless, it's a great result for a pump that does not require a carb intake. It simply requires the patient to put the meal portion, whether it's average, above, or below average. So hopefully this device might get the approval very soon, and we will hear more about it. So in summary, insulin pump is one of the basal bolus regimen options. The advanced hybrid closed loop pumps have additional features that help lower HbA1c and prolong the time and range. And minimize the glucose fluctuation. An insulin pump are of special value in younger age patients because they can deliver a smaller fraction of insulin doses, which is highly needed for those patients and cannot be done by using the insulin pen or syringes. Back to the question, in what year was the HbA1c established as the marker for diabetes control? And the answer is C. It is in 1976 when this article was published in the New England Journal of Medicine. This is a picture from Jabal Hafid in Al-Ain. Please come and visit us. Thank you so much for listening, and I'll be happy to take any question or comment. Thank you.
Thank you very much, Dr. Walid. Okay, we will have now discussion for 15 minutes. Can we have some chairs there? Yeah. Until we have the chairs up, we have a few patients on automated insulin pump. Half of them on 780G and the others on tandem T-Slim. And we found good results actually, but there is 2 patients, they gave us a new horizon of using the automated insulin pumps. They are the behavior. They are depending on the insulin pump and they are not doing calculation, they are not doing carb counting and so on. Some of them, they deteriorated rather than improving. Maybe bionic insulin pump will enhance this behavior. Dr. Asma, Dr. Afaf, please. And Dr. Aisha also. Okay, please. Okay. Dr. Adnan. Can we have one mic here and one mic with the... I think we can hear that. Okay.
Thank you for the speakers' excellent talks. I'm really impressed about the level of presentations we have. I have two questions, one for Dr. Aisha, one for Dr. Afaf. For Dr. Aisha, did you try or if there is published trials of using fludrocortisone, Florinef, in those patients? We know their aldosterone is very high, but this is a simple medication. Is there a trials using it? And for Dr. Afaf, is there a real a trial or a personal experience of using oral calcium on those patients and just avoiding the IV calcium in vitamin D dependent rickets type 2? And I'm impressed about the number of 25 hydroxylase rickets. You said 40 or something. Very interesting. Very interesting.
For actually fludrocortisone, during my review, I didn't come across any of the literature they use fludrocortisone. But from my experience, because I have few patients, when they presented before we got the aldosterone result, we tried with the fludrocortisone, but unfortunately they didn't respond.
Actually, we do have the largest cohort of pseudohypoaldosteronism followed at our center. Currently, maybe we have around 22 patients whom are pseudohypoaldosteronism. Some of them, the genetic test was negative, so they were not published in the cohort that was published. Fludrocortisone was started in the beginning with no good response. We increased the dose with no good response. Historically, when I used to be a fellow, these patients used to be admitted frequently to our hospital, like Aisha was saying, very frequent. We initiated a protocol to have a GT in these patients, and I treated them like CF patients with high caloric intake. I referred them to our dietitian, and she was helping with a lot of hydration. And again, the patients were more compliant with the therapy, because if you are taking frequently sodium chloride orally, you don't tolerate it much. So I thought compliance was the big issue why these patients were admitted frequently. With having the GTN, we achieved many purposes. One of them was that historically, these patients had very significant failure to thrive. Their average height was, I had a girl, she ended like 130 centimeters, final height. Her brother, whom we did change our protocols, and we started the GT. Now he's doing very well, he's thriving well, his weight is good, his height is approaching normal. And I think the trick is these patients need a lot of hydration, good caloric intake. You need to put a GT in them so they tolerate these medications. As they grow older, the frequency and of the crises are getting less and less with time. We achieved the stopping the treatment in one of the patients. At 6 years of age. I had one patient, an adult, she's 21 years. I inherited her from Dr. Saqati, and she stopped her medication and she's doing perfectly. We don't see, we saw some skin manifestation with some of them, but mainly it was the renal problem that we are countering. And frequently we had patients who had the lung problems, whom are followed with our pulmonologist. Some of them are, one of them had bad lung disease with her problem, but the rest actually are doing well when it comes to pulmonology. So fludrocortisone doesn't work, but I think GT do work in preventing frequent admission of these patients.
Thank you.
And calcium questions?
Yeah, the calcium questions. يعني maybe recently for the last 2 years I adapted giving oral. After having one of my patient father refused to go on IV, so we started oral. We put the GT and we started the patient on oral high doses. This patient is Nadine. She has a very perfect labs. She's taken 5,000 milligram oral calcium Q6 hourly. She's on magnesium, which is helping not developing the constipation and the GI symptoms. Sometimes she uses Moficol for that. And since Nadine, did a good example to me, I'm now, all my patients, I'm inserting a GT in them, trying, especially they're coming from outside Riyadh, and we helped in stopping their coming. And even the result of the oral calcium was better, because the IV, these patients, we give them for 6 weeks IV, then they go to their home, they come every month for 1 week. When they come, they are hypocalcemic, they're hypophosphatemic, so as we're going back to square one. With having oral calcium continuously at home given, that is supporting. You know, when we used to give them the medication to take it at home, they don't take it because the child refusing because you need to take it orally. But with the GTN and the family compliance, they're really doing good. The ones who didn't do well, the ones who are the family are not really compliant. Hopefully we'll publish the data on the oral, inshallah.
Thank you very much. Yes.
Doctor, give me 1 minute. Regarding the patient with the vitamin D resistant ricket, we do have quite a good number of patients. And I discussed last time with Afaf, we are treating them with calcium IV. We admit them once, a month for almost 5 days. And I noticed that as they grow up, their requirement of calcium is reducing. And their alkaline phosphatase normalized, their calcium is almost near normal, like 2. However, the bony complication is still there. They do have deformities. This is what.
Most of the outpatients.
Yeah, they have deformities. So the aim of the treatment here, either to normalize the calcium and to minimize the deformities. However, we are unable to reach a stage in which we can minimize or reduce the deformities, and they require quite surgical correction.
Our cohort didn't require surgical correction. They did one, but I think with the oral, I'm sure if you try oral at good doses, 5,000
Through the nasogastric tube or through the gastrostomy? Gastrostomy tube.
5,000 Q6 hourly, it looks much better than the IVs.
Yes. Thank you. Yes, please.
Thank you so much. Excellent talks, all of you. I agree with Adnan. It's a comment, Dr. Aisha. It's not even a question. Pseudohypoaldosteronism is a very bad disease, and the medication is not palatable. They take very high intake of salt and sodium bicarb and resonium, and those 3 medications really taste horrible. The problem with this disease is that when the children grow up, if you don't tell them specifically that this disease is life-threatening, you can die from it, they will start playing with medications. And this is very dangerous to pass. And I think it's very important that the treating adult physicians knows this and the patient himself knows this, because we lost a 16 years old child who was with us, transferred to adult. Nobody told him, the family did not tell him it's life-threatening, and the treating physician did not tell him it's life-threatening. He stopped the medication for 2 days and he arrested, taken to the ER, and they couldn't revive him because of the severe hyperkalemia.
Okay.
So I think this is very
This is what
important.
I presented for the Europe 1 study. I liked the complication they put it, because they studied their patients up to the adulthood. So the cardiac arrest is there, and they're reported for 2 patients. They died because of the cardiac arrest due to the arrhythmias.
Actually, one of our patients, he arrested early in life. He's now like.
Okay. Any question? I have a question to Dr. Asma regarding using of the technology. We know that it's helpful in case of seeing the patient frequently, also nearby appointments and so on. In addition to using the technology in monitoring and also treatment. Do you, in your research or studies, do you find any difference between those who's coming from outside and those who are really in Gulf area or residents of Gulf area in regard to accepting these technologies and the improvement on these technologies?
I'm not sure if I got your question correctly. So the two population you're talking about is the population in the Gulf. What's the other population?
Actually in Dubai and Qatar, we saw a lot of patients coming from outside. They are
okay.
like United States. They are not Gulf residents. And we found that they are accepting the improvements better. But do you find any difference between those?
This is a very interesting question. I don't think it's a matter of what the ethnicity or nationality or the background. The only difference is sometimes we see expats cherish the treatment more because they are not insurance covered and they have to self-pay. So I'm not sure to what extent that is applicable to the type of people and to what extent it makes them more compliant. I feel that children are children and diabetes is diabetes, and I'm not sure. I haven't got any data to back my answer up, especially from our region, but from personal observation, if you are paying money for the device, you use it more properly because you feel you are paying for it from your pocket. But
I have a comment on that, Asma. Dr. Wade Qabalan presented a poster in the last SPAD meeting where he compared all the populations, the local versus expat.
Great.
And he showed that the local are doing really worse in terms of A1C control versus the expat.
Okay.
So there is a difference in Dr. Waleed's Qabalan's cohort.
Okay. Yes, Dr. Adnan.
Just a comment and a question. Comment regarding the name of vitamin D dependent rickets. It's a bit, I think it's a wrong name or mislabeling. I think the proper name should be vitamin D resistant rickets because we know that there is a resistance with the receptors mutation. So it confused the juniors when they read in some books the labeling as vitamin D resistant rickets, and other references, they will read it as vitamin D dependent rickets. I think maybe in one of our meetings we should agree on using really the proper name. And the question to Dr. Afaf, back to vitamin D dependent rickets. 25 hydroxylase deficiency rickets. Now we know physiologically that there's at least 5 isoenzymes or seroenzymes, like 5. So if there is a mutation of one, why the remaining 4 enzymes of 25 hydroxylase doesn't do the job? Can we ask Dr. Waleed question? Or Kaplan, is he with us?
Actually, we don't have any more time. Please, Dr. Afaf, if you can answer this question, then we'll close the. Yeah.
Actually, we had 40 patients whom we did sequence the gene for them. Specifically, we did the CYP21B, and it turned to be positive in 30 of those patients. 10 of the patients had negative mutation. So these 10 patients. I didn't have a researcher who was interested in trying to identify where is the mutation, but they had the same features. They were responding to high doses. They were very dependent on vitamin D. The 25 continued to be low. So they have the same phenotype. So I believe we are still learning, and we'll learn more. And I'm sure if you look to our population, you see most of us are dependent on vitamin D. Why are we so dependent? And some of this require very high doses. Why were we requiring these very high doses? And I had a patient yesterday in the clinic. I didn't do the genetic test. It was Bassam's clinic. I was covering it. So I noticed that this patient, whenever we lower her dose, she just goes to get rickets immediately. It's not just deficiency. And family were not that compliant. So I sent her genetic test yesterday. So you could find in your clinic similar cases, and it may turn to be positive, and maybe still there is a lot of knowledge to be learned.
Thank you very much. At the end, we would like to thank all the speakers, Dr. Asma, Dr. Aisha, Dr. Afaf, and also Dr. Waleed, and thank you for your attendance. Thank you very much. I think now it's the time of lunch and they are waiting for you. They are not starting until you come.
بس لما يطلع نيجاتيف صدقيني اتس مور اكسايتنج معناها في شيء ما زالوا ما اكتشفوش.
اليوم عندنا الجينوم الان سنتر يقولوا لي ابدا تعالي لنا بين مشروع and we work with you. قلت لهم والله I have come بس خليني